Hey everyone, Vince Lau here with another point of care ultrasound podcast, this time on peripheral IV insertions for procedural guidance. This talk is geared towards nurses and medical students, but can also be used by other healthcare professionals such as medicine, surgery, emergency, anesthesia, and ICU to learn peripheral IV access when it is difficult to do by standard visualization. Getting to the case, we have an 84-year-old male admitted with urosepsis and bacteremia and is ordered IV antibiotics. Unfortunately, there's no good IV sites to the naked eye, and he's a previously difficult poke. IV access has been attempted 3 times to no avail with the palpation and blind techniques. This is not an uncommon scenario in medicine to have no IV access visible to the naked eye, but 85% of patients can receive an ultrasound-guided peripheral IV, obviating the need for a central venous line. This technique is faster and is more comfortable for patients with fewer pokes. It is also associated with a lower complication rate compared to non-ultrasound guided techniques, 2.25% versus 15%, mostly associated with bleeding, infection, and failure to cannulate. Better success is achieved when the size of the vein is large enough, at least 0.4 centimeters, to accommodate an angiocath, and also when the vein is not too deep, at a max of 1.5 centimeters. Otherwise, the cannula will not reach a depth past that. Using the correct size of angiocath is also important. There's increased success with the longer IVs, 1.88 inches, as the shorter ones, 1.16 inches and shorter, tend to fall out. I typically use the upper extremity for IV cannulation with ultrasound guidance. We will be focusing primarily on the antecubital fossa, where we see here the basalic vein continuation, the cephalic vein continuation, and the bridge between the two, the median cubital vein, which are all good for IV cannulation peripherally. The upper cephalic and basalic veins can sometimes be saved for PICC lines, and peripheral IV insertions into the upper arms can make PICCs more difficult in the future. However, the liberal use of these veins with ultrasound guidance can also save the use of PICC lines if a good peripheral IV can be inserted, as we will explain at the end of the screencast. The brachial veins in the upper arm are harder to cannulate as they flank the brachial artery, but with enough skill, they can be used as well. The forearm veins below the antecubital fossa can also be cannulated using ultrasound guidance, but they may be more superficial. So we first start out in the antecubital fossa in one of the patient's arms to screen for appropriate veins for peripheral IV insertion. We have a linear probe, seen here. The index mark is to screen left, hence the probe orientation should be to the operator's left or the patient's right. We see an antecubital vein in view that is less than 1.5 centimeters in depth, indicating this would be a good vein to cannulate and it's not too deep. The marks on the side are about 0.5 centimeters, and therefore the vein appears to be of adequate size, close to the 0.4 centimeter cutoff, using the ruler on the side as an eyeball method. As we play the clip, we compress the structure to confirm that it's a vein, and it collapses, meaning there's no clot to prevent peripheral IV insertion. We can also put color across the vein to make sure that it's not pulsatile flow with arterial blood. The flow that you do see is from squeezing of the forearm to increase venous return to confirm that this is a venous structure. Once we've screened for an appropriate vein, we need to gather some equipment for IV insertion. That includes a tying tourniquet to increase the vein size by tying it above the elbow or antecubital fossa. Also, we need to choose an appropriate gauge size needle, but we also want the longer length of 1.88 inches. Remember that the diameter and size of the needle is inverse to the gauge size. Therefore, a 14 gauge needle is larger in diameter than a 22 gauge needle. Typical selection in the AC would be a green 18 gauge needle or a pink 20 gauge needle. However, you can use different sizes in the AC depending on the size of the vein that you have. We also need alcohol swabs to prep the antecubital fossa, and then we also need ultrasound gel for the probe. We also need a 10 cc flush prep to an IV connector, and also dressings for securing the IV once placed. So we've already started by tying our tourniquet above the AC, sterilizing the fossa with alcohol swabs, and we've placed gel on the surface of the skin and placed our linear probe down to visualize the vein we picked out for cannulation. Once we play this clip, we see the short axis technique of insertion, where we keep the vein in the middle of the screen and then use the center of the probe, which has a mark on it, to line up our needle. Then we advance the needle while following the tip with a slide or creep technique, and we make sure that the needle does not pierce the back wall of the vein. We should see flashback going into our chamber, and then we would advance the plastic catheter over the needle after doing a sweep to see that we are still in the center of the lumen. So here's another clip of peripheral IV insertion, this time with a switch from the short axis to the long axis in the middle of the clip. So as we play it, we can see that the creep technique or slide technique is being employed as we see the needle tip, and then there's probe movement advancement, and we see the needle tip again, and eventually we reach the anterior surface of the vein. And we stop here before cannulating the vessel. Next, what we do is a 90-degree turn so that we see the vein now in long axis, and now we see our needle immediately above the vein, and we cannulate it and advance the needle so that we don't puncture through the back wall. Once we're happy with the needle position, you see the advancement of the catheter over the needle and eventual withdrawing of the needle. We can confirm this by switching back to short axis and following it from the surface and seeing that the cannula is in the middle of the lumen. And we can also switch back to long axis to confirm this, with the cannula clearly in the middle of the lumen without puncturing the back wall. If you're by yourself and you're trying to concentrate on advancing the catheter, please feel free to put down the probe and using your probe ham now, which is now free, to advance the catheter into the vein instead. Now you can hook up the peripheral IV to your lower lock system, draw back and flush, and finally dress the IV to secure it. Please check out any of the other screencasts on the website. We hope you join us again in the future. Thank you very much. Have a nice day.